All right. So, cardiac is my favorite, but if I had to choose a backup to teach, I don't like these kind of patients because neurological patients can be a handful. But I would say that the brain is pretty interesting. I mean, it kind of does some important things like the heart does, but I still love cardiac first. But I will say that neurological, if I had to choose a backup, would probably be my second favorite thing to teach because it's got some cool stuff and it does some cool stuff. So let's get in and get some of these questions. Remember, these practice questions are here to start digging deeper into content, but also to start looking at some test taking strategies. So question 1, what assessment finding would put a client most at risk for increased intracranial pressure? ICP question. So I already know in the question that I'm answering, I'm looking for assessment findings, or there's assessment findings here. And I'm seeing which assessment finding is most related to or put someone at risk for increased ICP. So one thing you can do when there's assessment findings is you want to look through and see if, like, you can always start with a question like this if you're really overwhelmed or maybe you don't know a lot about ICP. And one thing you could do is go through and cross out the ones that are normal or okay. So I could cross out answer choice A already because 99 beats per minute, that's normal. That's within normal range. That can't be it. That's something normal. So then I'm left with a high blood pressure, a high temp, or a faster respiratory rate. So for this, I would have to know about increased intracranial pressure, what things make it worse. So things that can make intracranial pressure worse is low blood pressure. So I think that higher blood pressure, I mean, we definitely don't want it too high, but it looks like they're getting blood flow to their brain. So I'm going to cross that one out too. So then I'm down to a patient with a fever or a patient that's breathing 22 breaths per minute. And so if I had to go down between those two, if I look which one's more severe, the fever is a lot worse than that 22 breaths per minute, which is kind of right outside the bridge of normal. But if I had knowledge about increased intracranial pressure, I would also remember that it's a decreased respiratory rate that we worry about, because decreased respiratory rate leads to more carbon dioxide, and more carbon dioxide can lead to vasodilation in the blood in all of my blood vessels. And as a result of that, it can lead to pooling of blood. So there's less flow to my brain. Also, if I know that fevers increase my metabolism, they cause my brain to work. And so it's going to cause more pressure. It's more work on the brain. And so the best answer here is going to be C, which is the fever. So the one that's going to put a client most at risk, again, it's not saying that these others can't possibly put them at risk, but it's saying the most risk is going to be from the patient with a fever. So question 2, another assessment question. A nurse is performing a neurological assessment on a client. Based on the assessment findings below, what should the nurse score the client for the Glasgow Coma Scale? So it's kind of telling me, hey, I'm rating someone's GCS. So with most GCS questions, at least where I work, we're not trying to have you tell the difference between a 5 and a 6. We really just want you to know, what's the highs, what's the lows, what generally should this patient look like? So the Glasgow Coma Scale, and I have a video on this, is that it has 3 different scores, and it's eyes, and the highest you can get in eyes is 4, the lowest, yeah, I said that right. The highest you can get is a 4, the lowest you can get is a 1. It has speech, which apparently I suck at tonight. So the highest I can do for speech is a 5. The lowest I can get is a 1. And then the lowest, the motor is the highest is going to be a 6, and the lowest is going to be a 1. So at the minimum on a GCS, it has to be a 3. So I know that, all of these are possible choices. The maximum it can be is 15 if I had everything perfect. But I'm looking at this really briefly, and I'm already seeing there's something abnormal. There's multiple abnormal things. So I have to really start kind of breaking things down here. So there's a couple ways of looking at this. Let's say that you just don't have your scale memorized, and that's okay. I could cross out some of these just looking at this, because really, if you remember, Glasgow Coma Scale tells you how awake a patient is. So let's say that I didn't have all my scales memorized, but I'm looking at this. They're withdrawing from pain. They open their eyes only to pain, and they're moaning but not saying any words. That's not very awake to me. Now, it's a 3 means they're doing nothing. So I'm going to cross out A because they're doing something. There's still some response here. So I don't think it can be A. And I'm also going to cross out B because 14 is almost completely normal. normal, but there's multiple things wrong here. So I don't think they're at the low end. I don't think they're at the high end. I think they're somewhere in the middle. But I really am asking myself here, are they super low, like a 5? I'm like almost, like to the point where they're not doing much, or are they a little bit higher and they're an 8? And if I had to guess, they seem like they're somewhere in the middle. They're waking up a little bit, but they're not doing a whole lot. So I could kind of guess that they're in the middle. But let's do this the right way if we do have our scale memorized and kind of look through. So first, let's start with the top and let's look at what their eyes are doing. So their eyes are opening to pain. So your GCS scale, it goes 4 means they open their eyes spontaneously. I'm going to make sure I don't put my middle finger up. So yes, 3 means that they open their eyes to speech. So far we're not there because it's pain. 2 means they open their eyes to pain. So far we have 2 for this patient because they open their eyes to pain. The next scale is the verbal. So they get a 5 if they open, if they are oriented. So this patient is moaning, but not saying anything discernible. So definitely not 5. So 4 means they're confused. No, they're not saying any words, not answering any questions. So 3 means is that they are saying words, but their words don't make sense. And it says, no, they're not saying any discernible words. So really that gets us down to a 2, which means they're making noises or moaning, but not actually saying any words. That's where they're at. So far we have 4. We have 2 for eyes and 2 for verbal. The last is motor. And so with motor, what we start with is 6. So 6 means they follow commands. Now they're not doing that. 5 means that they localize to pain, and they're not doing that either. They're not localizing. 4 means they withdraw from pain. So that's where I'm at. So I've got 4 for their motor, 2 for their eyes, and 2 for their verbal. That equals a total of 8, which makes D our correct answer. So question number 3. Says a client is experiencing pain related to tension headaches. The nurse has given acetaminophen and ibuprofen with minimal relief. Which intervention would be most helpful to this client? So pretty much this patient has a tension headache, which you all as nursing students are probably very familiar with. And so we've given medicines and we've given, Tylenol, we've given ibuprofen, and there's minimal relief. So it's saying, what else can we do for a patient with tension headaches? And it's also saying, of course, what would be most helpful, which means some of these might be helpful, but what's going to be most direct and most helpful? So the first one says administer oral propranolol. And so that's a beta blocker. I know that can be used. We've already tried meds and meds don't seem to be working. And it doesn't mean that we can't try any more meds, but I just really have to think, is this going to help? And if I remember correctly, beta blockers are used to treat they're used to prevent certain types of headaches, but I don't think they're used as an acute treatment. So I'm going to keep going. It says, turn off the client's room lights. Well, if they have sensitivity to light, that definitely could help. But I don't think tension is about sensitivity to light. I think that's more migraines. And this is another question, again, with you have like tension headaches, you have migraines, and you have cluster headaches that we study. So you really want to think about, okay, which one is some of these answers might be true for other types of headaches, but not for this one. Put the client on oxygen via face mask. Now, I know we do this for cluster headaches because the oxygen helps with vasoconstriction, which helps reduce the headache, but I don't think it's used typically with tension headaches. Then put a heat pack on the client's neck. Now, this one appeals to me because I like this because it's talking about a heat pack. In tension headaches, it's like a band around your head, but it can also cause neck tension. If I put a heat pack on their neck, it might relieve some of that tension and help. Really, this is testing, and I know you might be thinking, oh, ibuprofen and acetaminophen didn't help. How's a heat pack going to help? You have to think about, don't think realistically. Remember, perfect nursing school world where our little interventions make a big difference. But you also have to think about, are any of these others actually going to be helpful to them? The oral propranolol is preventative. It's not going to do anything. Turning off the client's room lights doesn't do anything because this is not a result of too much stimulation or outside. And the oxygen via face masks, that's for cluster headaches. That's not going to directly be helping with this specific type of headache because this type of headache, based on a lot of times what's caused the stress and the muscle pain. So because even let's say that I give this and I have less vasodilation, I have more constriction, it doesn't take away the tension that's in my neck. So the only thing that's going to really get to the bottom of the problem, and again, I don't want to give the impression that people with tension headaches have them because of tension in their neck. What I'm saying is that, this is the actual adjunctive treatment to help with tension headaches is going to be to relieve some of the muscle pain because this can help with it. But you have to think about what's most specific to tension headaches. So generally oxygen is only used mostly for cluster headaches. I read some research that maybe sometimes they use it for migraines, but really I've never seen a patient with a migraine that were like, apply, put them on a face mask, and so usually that's only for cluster headaches. So heat pack is the most appropriate intervention here. So question 4, a nurse is teaching a new graduate RN about the rationale for administering oxygen for a client with cluster headaches. Oh, hey, look, I might have already answered this one, and I'm sorry. I should shut my mouth more when I'm I don't always remember what questions I write here. It says, what statement by the new graduate RN best indicates teaching was effective? So to remind you, so like a nurse is teaching a new nurse about why we use oxygen for cluster headaches. And so it's asking which demonstrates that teaching was effective. So again, these are questions, do I want to know what's good or what's bad? In this one, there's 3 bad and there's 1 correct or good answer. So let's find which one's right. Does cluster headaches decrease oxygen levels so the oxygen helps stabilize oxygen levels? Okay, I had to read that 4 times. I was like, what did I just write? So cluster headache, it's saying that cluster headaches decrease oxygen levels, so we need the oxygen to stabilize or increase them. Now, I don't think cluster headaches decrease oxygen levels, so I don't like that answer. I'm going to keep going. Oxygen helps to provide comfort to the client with the intense pain that they're feeling. Oxygen, some people do find it comforting, but I don't think that the oxygen itself actually brings them comfort. So I don't really like the sound of that one. It says oxygen reduces vasodilation in cluster headaches, which can help to rapidly reduce pain. Sadly, I just said that, so you might already know that's the correct answer, but let's just keep going and act like I didn't ruin it for y'all and keep going to D. It says cluster headaches cause hypoventilation, so oxygen is used to support effective breathing. Well, I don't think the oxygen can change your breathing, not necessarily as directly as that. If they're hypoventilating, it's not oxygen that's going to fix them. There's a problem with it because respiratory is all about, I have to oxygenate and ventilate, and ventilating is a muscle function and a brain function. So I don't think oxygen is going to change my hypoventilation. And I don't know anything about cluster headaches and hypoventilation. So I think the best answer here is going to be C, which is that oxygen is a potent vasoconstrictor, and that vasoconstriction can help in cluster headaches in order to reduce some of the pain they're feeling. So this is something we use acutely, and patients that have cluster headaches can go home, so they need oxygen education. So they're going to be put on 100% via face, face mask. Or non-rebreather, I should say. And so they're going to be put on that to rapidly reduce their pain. Because it helps to vasoconstrict against the massive vasodilation, because all headaches are just a vasodilation. Oh, stroke questions. So a nurse is caring for a client who's being admitted with a possible stroke. Which priority orders will the nurse need to complete to help determine treatment? So let's look at this. So possible stroke, so we don't know if they've had a stroke yet. So in order to determine, like it's not just saying what orders am I going to need in general, which orders do I need to complete to determine treatment? So it's specific. It's a select all that applies. So it's pretty much saying which of these, in order to know what to do next, do I need, or the doctor needs to know what to do next. In order for the doctor to know what to do next, what do they need to order? So the first one, lab, blood glucose. So you might be thinking this is just a giveaway because possible stroke, blood glucose, where's the connection? But I know that a stroke and hypoglycemia can look the same. So we might need to check a blood glucose to make sure that they are not just hypoglycemic before we start giving them medications to treat their stroke. So I'm going to say yes for A. Assessment, NIH stroke scale. So in order to treat someone for a stroke, they have to be having symptoms of a stroke. So to do that stroke scale, I am going to need to get a baseline to know where their mental status is at. So I also need to know, okay, if I'm going to do treatment, I need to know if it's effective or not. I'm only going to know that if I get a baseline. Assessment, heart and lung sounds. So this is another one of those that a lot of times students stick to because they're like, ooh, we have to listen to everybody's heart and lung sounds. But is their heart or lung sounds going to tell me whether or not that I can give or the doctor can order their TPA or other treatments? And not necessarily. There's not really anything that I probably will listen to heart and lung sounds before we do any treatment, but it's really saying, do heart and lung sounds determine what kind of stroke they're having, if they're having a stroke or not? And not really. Nothing about the heart or lung sounds. That might tell me about other stuff that's going on with them, but it's not going to tell me specifically about the stroke. In other words, there's no symptoms or there's no findings in heart and lung sounds that specifically point to a stroke or information I need to know if it's ischemic, hemorrhagic, etc. Labs, PT, PTT, INR. Well, this is all about clotting and coagulation, and some of the medications I give for some types of strokes can cause you to bleed. So I think I would want to know that, because if I know that, it might tell me if they're already bleeding, etc. So or if they're at high risk, because I know that some people that have strokes have the bleeding strokes or the hemorrhagic strokes, and sometimes it's because they're on like warfarin and stuff at home. So I think I would want to get that. So far I have A, B, and D. Let's look at the next. A CT scan of the head. So I think this is one of my top things, because I need to see what's going on in their brain. I need to see if they're bleeding. I need to see if something's going on. So I definitely need to get a picture. So I'm going to say A, B, C, and E. The last one is, did I say that right? A, C, D, and E. Sorry, A, C, D, and no, oh, sorry, I'm messing up. A, B, D, and E. Oh my goodness, I'm losing my mind. A, B, D, and E. So far, the only one I'm not going to do, not that I'm not going to do, let me rephrase that. The only one that's not imperative that I absolutely have to do in order to determine treatment is the heart and the lung sounds. Last but not least is lipid panel. Now, stroke is related to a lot of times ischemia. It can be a plaque problem. But I have to say, like, is getting the lipid panel going to change the course of my treatment right now, or, help provide life-saving treatment? No, like knowing those numbers, regardless if their cholesterol is high or if it's not going to change the fact that they need treatment for their stroke. So I don't think that there's anything that's going to be helpful. So for this one, let me make sure I do this right. I'm going to check A to make sure that they're not just hypoglycemic, B, in order to make sure they're having symptoms and qualify for treatments, because they have to be having a stroke in order to be treated for a stroke. D, to check to see if they're having any bleeding issues or high risk for bleeding. And then E, to see what's going on in their brain, if they're having, if there is any bleeding in their brain or signs, that sign of damage. Now, with a CT of the head, we cannot see ischemia, or like if it's a ischemic stroke, but we can rule out that they're not bleeding, and then see if they're appropriate to receive TPA if it's an ischemic stroke. Alrighty. Oh man, 2 selectable that applied back to back. So question 6, a client is experiencing left-sided hemiplegia, impulsivity, and expressive aphasia. Which interventions are most appropriate for this client? Select all that apply. Ooh, so they have a couple things going on. So I have to know what some of these big words are. And a lot about stroke is knowing there's a lot of terminology that sounds super scary. So they have left-sided hemiplegia. And so I always think hemiplegia is like paraplegia, except it's split down this way. And so that's where they have left-sided, and plegia means like paralysis. So this, I think of they're incredibly weak or completely flaccid on that side, on their left side. They're also impulsive. So they're showing signs of maybe like there's like, I'm thinking safety issues. They have expressive aphasia. And so expressive aphasia is where they have trouble expressing themselves, like, which apparently I have all the time. I think it's actually called that I need more sleep. But yes, I'll do the best that I can. So needless to say, I don't actually have expressive aphasia. I think, is it Bruce Willis that has that now? Somebody, famous has that now. I do not actually have expressive aphasia, but sometimes I feel like I do, but I'm trying to give it as an example. Expressive aphasia is where the information and knowledge is up here. They're not non-intellectual people. I can't even talk about being intellectual. It's not that they're not smart. It's not that they don't understand you. It's literally the words are up here, but they can't seem to get from up here then to actually get to the point where it's out of their mouth. So I know that with expressive aphasia, they speak in like little short phrases or sentences. Sometimes they only have 1 or 2 words. Sometimes they can only say yes or no. Sometimes they can only say yes. And so it's really just about, they have something in their brain, but they can't get that communication out to you. And so they can get frustrated sometimes. So let's look at this. So what interventions are most appropriate? So I need to see, I really need to ask myself for each of these, is this appropriate for someone who has left-sided weakness and or complete flaccid nature to those extremities, someone who's impulsive, and someone who has trouble getting their words out or communicating with me? So the answer choice A is speak clearly and slowly to improve communication. So this may seem like something that would be helpful to anybody. Of course, I want to speak clearly and slowly to improve communication. But you have to think if it's specific that will really help this patient. With expressive aphasia, if I sit there and let's say they're trying to go to the bathroom and they're trying to tell me, they're like, I, like that's all they could get us. I. And I'm sitting there, I'm like, what do you need? Like they're, again, they can hear me. There's no hearing deficits. They can comprehend what I'm saying. They just can't get the words out. And so speaking clearly and slowly, it's not, again, it's not that it's going to be, it's not that it's at some level maybe going to be somewhat helpful, but is it really appropriate for this kind of, and it can actually make them feel worse, because if you're talking down to someone, and you know, talking to them in a way that makes them feel like, you know, it makes them feel worse, but they're like, man, I hear you, I understand you, I'm working on trying to get it out. A lot of the interventions for expressive aphasia about being patient, giving them more time, and giving them something. Like with a lot of communication with aphasia, you want to think about, do I have a problem communicating to them and I need to do something different, or are they having a problem communicating with me, and what do you call them, I need to give them a tool to communicate with me. So the best things to help with expressive aphasia that are most appropriate are going to be tools to help them communicate with me. So it's going to be giving them more time, and it's going to be giving them things like communication boards to allow them to point to things in order to have, because they have trouble getting those words out. A lot of people say like writing, but I'll tell you with writing too, if someone has expressive aphasia, they can have trouble speaking or writing. So speak clearly and slowly. I wish I knew what answer I chose for myself when I wrote this question. But I usually defer with this one. Like, yes, we want to speak clearly, but we don't need to speak slowly with these patients. Speaking slowly is not going to change the fact they're receiving my message just fine. They just can't express back what the answer is. So I'm going to say no to A. I know that some of y'all are probably not going to like that, but we really have to think about what's most appropriate. Place objects in their right side field of vision. Well, there's nothing here that's talking about a vision issue or any sort of neglect. So I don't think that's appropriate. So I'm going to say no. Use gestures to enhance communication. So again, this is a good example. So I can say that, let's say I'm saying like, you need to go to the bathroom, or like doing some weird hand gestures. They're going to look at me like, I understand what you're saying, I just can't get the words out. So again, anything that's looking at me changing how I'm sending my message is really more, it's more helpful for people that have receptive aphasia, that they're having trouble. Like gestures are, I should say, at least for gestures, these are super helpful for people with receptive aphasia, because it can help them sometimes, because with receptive, they have trouble receiving my message, and I have trouble receiving theirs too. They're saying a bunch of words, but they don't make sense. So gestures can be super helpful for them. But for someone with expressive aphasia, is what do you call them? And again, you might be asking the question, well, utilize gestures, is that talking about them or for me? And to me in this question, I'm going to change. I know that it doesn't actually say this, but I'm going to have the this is talking about what the nurse is going to do. And as the nurse, I do not need to utilize gestures for these patients, because it's just going to make them feel stupid. Like I was sitting there, you need to eat. Like they hear me, they understand me, they just can't get their response back out. And so at the end of the day, I really want to think about what's going to be most helpful. And so far, there's none of these are appropriate or going to be helpful. It says utilize a hand cone and pillow for left upper extremity. So if they have hemiplegia, or that weakness or almost complete paralysis of their it's left-sided, so it'll be on this left side, then that does sound appropriate. A hand cone is an anatomical structure. It helps to maintain a regular anatomical position for their limb, and so it's going to help to prevent contractures and things like that. And so in elevating it is also going to help, because it helps to reduce any swelling that they have, especially if they're not as mobile on that side. So that seems appropriate. It says place an orthotic foot drop boot to the right lower extremity. So I like foot drop boots, but I do not know that it's going to be appropriate to put it on the right lower extremity. Even with the orthotic boots, they usually help with people with hemiplegia. You have to read these questions carefully. If this said place an orthotic foot drop boot to the left lower extremity, this would be correct, but it says right lower. And someone who has hemiplegia, again, they're going to have weakness on one side, but there's nothing to show that they have weakness on that right side, or foot drop on that right side, to require them to have a foot drop boot. And the last, it says, when leaving the room, ensure a bed alarm is in place. Well, they're impulsive, so absolutely, I want to have a bed alarm in place. So I think the right answers here are going to be just D and F. Everything else is not as specific or won't be most appropriate or most helpful to this client. So question 7, a nurse is preparing to administer TPA to a client being admitted with an ischemic stroke. So this is a med question specifically for ischemic stroke. Which statement, if made by the client, would be most concerning in relation to this medication? And so they're preparing to administer, so they haven't administered yet. And really what this question is asking is which of these is a contraindication to receiving TPA? So I have to see which is most concerning. So which of these would bring up like, ooh, I don't know if this is appropriate for him. And so with TPA, I know it's stuff that it causes you to bleed really bad. So I'm going to look for things that would lead to like a high chance of bleeding. So, and that's something you can do in questions. I'm really not a big fan of students that box themselves in, like on an actual, like when you're studying, it's great to think about, oh, what could the answer be? When you're on a test, if you're on a test and you say, oh, the answer is this, I know my professor said it 10 times, but then you're looking at your answer choices and your answer is not there. It can really get you like so frustrated because you're like, no, the answer has to be, green leafy vegetables. But if that's not there as a choice, and I'm not saying for this one, but, let's say that was what's in your head. And you have to keep in mind that a lot of times you can start changing other answers to make them like your answer, or like you just get frustrated, you just get defeated. So you always want to ensure that you are looking at it's okay to have an idea of what the answer might be, but don't get boxed in and say the answer has to be this. So like I said, having a general idea, hey, it's going to be stuff with bleeding would be good, but I don't want to say, oh, it's going to have to be they had surgery last week. So yes. So let's go here. Oh, I didn't realize there was one that said last week. Ha, that's funny. So it says client states I have a history of diabetes. So I have to think about, if they have a history of diabetes, would that stop them from being able to get TPA? Well, diabetes itself doesn't necessarily make you bleed more, and having that in their history, I can't imagine that would stop them from getting TPA. So I don't think that's concerning, because again, it says most concerning. So some of these things could be concerning too, but what's most concerning? I have an out of hospital, do not resuscitate. Well, this is understanding that do not resuscitate does not mean do not treat. So it doesn't change the fact if they want and are planning to receive treatment. TPA is not like a restart for their body. It's going to treat if they're having a stroke, but it's not going to invalidate that or have anything really to do with that. The next one is I had a cardiac catheterization last week. So this one, not just the fact that it says last week, but they had a procedure. And if you know what a cardiac cath is, there's a puncture wound there. So I'm a little concerned because if they have a recent procedure where there's a portal from inside their body to out, where something could, there could be bleeding or other things that could happen, I'm going to be a little concerned. It's like anyone who has a recent incision. And then the last one says I had a colonoscopy 4 months ago. So that one's a little bit farther on. It's a colonoscopy. So it's a semi-invasive procedure, but what I mean is there's no incision. They went up the person's butt with the scope, but there shouldn't really be as a risk for bleeding when it comes from having a colonoscopy 4 months ago. So the only one that I think really is going to increase the risk of bleeding or something that could lead to bleeding is going to be C, that they had the cardiac cath last week. All right, last but not least, a nurse is caring for a client who is admitted with an open femur fracture. The client stated that they had a tetanus booster. Ooh, it's a tetanus question. 8 years ago. What response by the nurse is most appropriate based on this information? So usually with tetanus questions, we're either, talking about tetanus in general, who's at risk, what does it look like, treatment, or we might be asking a question about, okay, like what actions are you going to take, or who's appropriate, who needs, like tetanus shots, etc. So there's always going to be a table usually in your book that will tell you and break down like, okay, when is like how often do we need to get a tetanus booster? So this person, they had one 8 years ago, and let's kind of read through these choices and see what the nurse is telling them. So A says, since it's been a long time since your last booster, apparently I'm getting country as the night goes on. It's amazing how you, not even being from Texas, you can get country, get a booster as time goes on. Let's try this again. Since it has been long since your last booster, yeah, what do you call it? I'm so glad I can entertain myself. You will need to receive a dose of tetanus immunoglobulin. So that's the TIG. And I don't know that they need the TIG. So this is one of those things where like the first half of the answer choice I like, but the second half I'm not a big fan of. So since it says, since it's been so long since your last booster, I like that because it has been a while. I think we want to get one every 10 years, but I don't know that they need to get TIG. So let's look. Let's keep going. Tetanus boosters are only required for those who have had closed fractures or very dirty wounds. So, I think this is testing my knowledge here because I think that tetanus boosters are for those that have had open fractures, not closed. Because if it's closed, if it's open, dirty stuff can get in. So that would make more sense. But I think this is another one, or very dirty wounds. I think tetanus boosters are especially important for those with very dirty wounds, but I think it's for open fractures, not closed. So tricky, professors. So then C says you will need a tetanus booster as well as a dose of tetanus immunoglobulin to prevent serious infection. So this is testing me to see, okay, am I going to need, am I going to need the booster or also the TIG? And I don't know if they're going to need both. I don't think they need the TIG, but let's keep looking. It says, due to having an open wound, we will administer a booster dose of the Tdap vaccine. That's the one I like the best so far, because if I would have to have some knowledge about the tetanus booster versus the TIG. And so just as a reminder, the tetanus boosters for anyone who, if it's been greater than 5 years since they've had their last tetanus shot and they have like an open fracture, they have like frostbite, open dirty wounds, stuff like that. We're going to give them a booster of their shot to make sure that they're well protected. TIG, or the tetanus immunoglobulin, that's used for patients that have, we have no idea when they have had, when their last tetanus was, or they've never had any treatment, any boosters, anything like that, in order to help them to prevent against tetanus. So we usually only use the TIG in those severe cases where no one has any protection. So look at it this way. Immunoglobulin, or TIG, is protection, or it's going to give you something right now to fight if you had tetanus or were super at risk. Whereas Tdap, that's going to take 2 weeks to take effect, and it's going to help to boost, my immune system against it, but it's going to take a few weeks. So if I have never had the tetanus vaccine, or I'm not finished, with all of my doses of it, I need something right now to help prevent or treat if I have tetanus. So the TIG is going to be the most helpful now, because it's going to give me antibodies right now to start fighting off that tetanus if I am really high risk for tetanus. Where the Tdap is just going to help as a whole to make sure to just kind of provide a little extra support. But that's if I've had, I believe it's a 3 vaccine series. If I've had all 3 vaccines and it's been greater than 5 years, that's when I would need the Tdap. So pretty much Tdap for if it's been greater than 5 years since my last vaccine and I've had all 3 of the first part of the series, and the 3 of the series. And then the TIG is for those that have had 0 tetanus vaccines, or they're not completed, or we're not sure about their vaccine history. So this will give them the best protection that they need. Because the reason there is that the Tdap, it's gonna, if I've had a Tdap in the last, like this person 8 years ago, they still have some protection on them, where someone else is going to need more, like the TIG, because they have 0 or not as much protection. Anyway, that is it for neuro. I hope that you had fun watching these videos as much as I had fun making them. See you next time.